Now, just to make the point, the two pictures on the left side of the screen are osteoarthritis, and reasonably bad osteoarthritis at that. Certainly the ones at the bottom look like they probably need surgery fairly soon. But what you can see there is there's almost no swelling, certainly no redness. With osteoarthrosis, the thing looks thick, not swollen. If the knee's injured and it becomes a bit arthritic, where there's inflammation, then there is some swelling, but it's never really that fully blown up. The characteristic of osteoarthritis is thickening. Now, if you compare the knees on the left and the knees on the right, you can see there's just no comparison here. Gout at the top, and I think it's an infective arthritis, but in fact, I know it's an infective arthritis below it. There's no comparison. So it's not that you're going to see a lot of gouty knees coming to your clinic undiagnosed. It's not that at all. At the very least, you should be able to say these are osteoarthritic knees. And right now, I'm not thinking you can do that because you're thinking they could be gout. So it's about you recognizing something that is completely outside of your experience. Not so much knowing that this is gout, certainly knowing this might be infective, and that's what redness really does indicate, but knowing that it's not your osteoarthritis. So don't regress to this familiar idea, this familiar bias. Just stick with what you know, the stuff you know, and then when that stuff doesn't appear to be, think of something else. Later on, you'll get a bit more skilled at it. But really, you need to look outside of your own little corner of medicine and start thinking about conditions that are not within your scope, and start looking at a little bit. Look at gouts, look at infections, study up on this stuff. Okay, plantar fasciitis. First thing now, posterior tibialis tendinopathy. Now, this is plantar fasciitis, so it's not tendinopathy. This is going to be a tendinitis, not a tendinosis. So what's the bias? This is the whole point of this question, is what bias is leading you to an incorrect diagnosis? So the bias there may well be availability bias, regression of familiar, but you need to say what the bias is to make you think about bias and understand it a little bit more. Overlapping tendinopathy, Pad Atrophy came up. This is the same instance of me talking about neuropathy because it's referring pain to the general area as it does. In this case, the pain is in completely the wrong area. Plantar fasciitis, plantar fasciosis, the pain is too far forward. It's too distal. Now, if this is a really bad plantar fasciitis, it may spread pain to the whole of the sole of the foot. But again, now we're looking at pain that just happens to coincide with the area. So Pad atrophy, Pad syndrome really isn't a good differential for plantar fasciitis. Better might be mid-tarsal arthritis or a distal calcaneal fracture. Medical conditions, neuropathy isn't it. Medical conditions, diabetic arthropathy would work for you, as would gout, but any of the systemic things that could cause mid-tarsal arthritis. Labral tear. So we've got one differential diagnosis, traumatic arthritis of the AC joint. Okay, or a traumatic dysfunction of the labral tear. So now I'm thinking that this labral tear is degenerative because you will have a traumatic shoulder arthritis with this. Bias here, availability bias. I've recently had a case of traumatic arthritis in the clinic, and that's exactly right. Perfectly good bias and reason for it. And he's also given the other reasons why he's picked that, which wasn't necessary. Biceps tendinitis, yeah, that's fine as well, but it should be tendinosis now. If we've gone to a non-traumatic glenoid labral tear or a degenerative glenoid labral tear, then what we should be looking at is a tendinosis rather than tendinitis. But okay, Again, they give me reasons why they picked that, and I don't care about that. Hill-Sachs lesion. Okay, this came as a medical condition, and it isn't. All right, now this is a case. This is a good case. When we talk about a medical condition, everything we treat is a medical condition. We treat in labral tears, you're not seeing that as a medical condition. We see osteoarthritis, and you don't really consider that as a medical condition. But of course, everything we treat is a medical condition. When we say medical condition in this context, what we're actually talking about is a condition that is beyond your scope of practice that you refer to the physician. That's your medical condition. Not picking one because you can't think of another one. And picking one that we treat. Otherwise, everything is a medical condition, and in that case, that question about medical conditions is nonsensical. So we all know that. Don't try and screw me. Okay, lateral epicondylitis. I think I have managed to cover this business about language adequately before I lost the plot on the Zoom session. Carpal tunnel pain. Actually, tension of the medial nerve motions. Cubital tunnel pain might have been better, but even so, it's not right for all the reasons we talked about. It's a neuropathy, wrong symptoms, wrong area, pretty much no overlap. This was about ranking. Why did you put your differential diagnosis in the order you did? Now, I'll address this when I talk about differential diagnosis on a different Zoom. But there's a reason for doing this, and mostly at the moment the reason for doing it is to make you understand the value of differential diagnosis. But clinically there's a reason as well. You can rank your diagnosis in any order you want to, as long as it's sensible and useful. So if I've got a calf tear, I can rank the calf tear in any order I want, from probable to least probable, from easiest to test to least easy to test. More importantly in this case, though, is from serious to non-serious. So the serious diagnosis for a calf tear is a DVT. The non-serious differential diagnosis for a calf tear is non-flexor tendonitis. So I would list DVT first and then exclude it. In actual fact, that should be listed as your diagnosis and then exclude that if you can. But that's not that easy to exclude, but it doesn't matter. The point is, list and rank your diagnoses. It'll become automatically at some point, but right now, you're not even trying to answer the question, most of you. Have a go at it. And it's not a matter of saying to me, well, this diagnosis has these symptoms, this one has these symptoms, and that's why I'm listing this one first. The reason is not that. The reason is this is more common than the other one. Okay, and that I think may have just been the ones of you who did that. It's probably just a matter of not understanding what I was asking for. The heel pain, again, you can't have plantar fasciitis for it. The pain is too posterior. It's at the heel pad, especially when I tell you the heel pad is tender. So in this case, the answer is fat pad syndrome, but we can be more specific. The fat pad itself was tender. I put that in the question, not the calcaneum. So we know it can't be an atrophy. We know it's not likely to be a dispersed fat pad or a displaced fat pad, because in both cases I should be able to palpate the calcaneum. So it's fat pad inflammation. Differential, sure. Calcaneal fracture, absolutely right. Where's the ranking again? So I would rank this calcaneal fracture first, followed by whatever it is you're going to do, subcutaneous bursitis. I would rank that first, simply because it's easy to test. I can do the calcaneal squeeze test, and if that's positive, then that goes back. If it's negative, then I have to think a little bit more. But mostly it's going to be positive if there's a fracture there. So that's why I would have ranked that. Okay, and then the last question. Non-traumatic pain, right lower C-spine. pain and spasm on full range extension of the right facet. Okay. Now, this wasn't the first question in that list, but let me address this first because this is the one only a couple of you got right. You told me that you treated the C5-6 with sub-barrier mobs to reduce pain, treat for spasm and pain. Most of you said that. Nobody wanted to actually treat it with high because of the word spasm, which is fine. But what you missed out on this question, most of you, was the fact that it was at full range. The joint had full range and spasm kicked in at the end of it. So this wasn't hypomobile. This was hypermobile. This is all the characteristics of a painful hypermobility. So the treatment was find what's caused it and deal with it. If you need to treat the local problem, then you treat it with pain modalities. But the main treatment here is get the stress off this so that all of this goes away eventually. The other one that was not well done by a lot of you was the 2 on the elbow. You was getting thrown by the different movement patterns that were painful and restricted. That's not definitive. What's definitive is the arthrokinematic. In both cases, the arthrokinematic was the same. It was at the ulnohumeral joint, so the radiohumeral joint wasn't part of the problem. There was no biomechanical dysfunction at the radiohumeral joint. It was at the ulnohumeral joint, and in both cases, a restriction of the lateral glide. So in both cases, this was an abducted ulna, and in both cases, you should have manipulated it. Okay, so I hope that eases the pain a bit. Again, I apologise for the Zoom session. As I say, I lost the plot there a little while. So this is actually what I wanted to say. So hopefully this will help. At the end of the Zoom session, I made an invite to anybody who wanted to take it up. That was, I'm quite happy to do more of these exercises, more of these sessions. You're going to get more anyway, because you have to change the way you think a little bit. This is all about making connections now. This isn't concrete, this isn't formulaic. You're going to have to be more flexible. So we're going to set up some exercises, not quizzes, but exercises for you to do to help make connections. And I expect these things sent in to me. But for anybody who wants some extra on that, I'm quite happy to set up more of this type of testing. I don't want to mark these. It's very time consuming and it's mind numbing, to be honest with you. And I haven't got a lot of time left to do this. And my brain isn't big enough now. I've lost a few cells. So I can't afford any of them to be numbed. But otherwise, I'll set up a separate Zoom session to answer the questions that I set rather than mark them out. That's an invite to everybody. I know there were some people who wanted to do this, so just email me via the Q&A and I'll be quite happy to set something up for you. Otherwise, take care everybody and talk to you soon. Bye.